Good day, everyone. Hope you all are doing well. This is SM Abdullah. I'm a member of the Health Economics Research Network and a PhD researcher at the Department of Health Sciences, University of York. It's a great pleasure to welcome you all to this HARN webinar. We sincerely appreciate your presence and engagement today amidst your demanding schedules. This webinar forms part of HARN's ongoing capacity building initiatives in collaboration with the Center of Health Economics at the University of York. Through these sessions, we aim to foster dialogue, skill development, and knowledge sharing in the field of health economics research. Today, we are particularly honored to host Dr. Peter Sivey, a reader in health economics at the Center for Health Economics, University of York, as our distinguished speaker. Dr. Sivey previously held academic positions at the University of Melbourne, Australia, and his research delves into critical areas including the economics of healthcare markets, provider competition, and medical labor markets. He also serves as an associate editor for the journal Health Economics. Today, Dr. Sivey will present an insightful discussion on a UK health policy evaluation using difference in difference approach. Difference in difference approach is a powerful quasi-experimental approach, particularly valuable when randomized trials are unfeasible. By comparing outcome changes over time between treated and control groups, DiD helps isolate the true effect of an intervention from general time trends. In this session, Dr. Sivey will walk us through the foundational principle of DiD, such as critical assumption of parallel trends, and explore its application within complex health service evaluations. He will also address methodological challenges and strategies for enhancing causal inference using DiD in real-world policy context. We trust this session will offer significant value to emerging and experienced researchers alike, especially those with a keen interest in health policy and impact evaluation. Before we begin, a quick note on housekeeping. The chat box will remain open throughout the session for your questions. Please feel free to post your queries as they arise. We kindly ask that all participants keep their microphones muted to maintain a smooth and uninterrupted experience for everyone. With that, it's my great pleasure to officially welcome Dr. Peter Sivey to today's session. Thank you once again for joining us. We look forward to stimulating and enriching discussion. Peter, over to you. Thank you.
Good morning, everyone. Thanks very much for being here, and thanks for that very kind introduction, Abdullah. So I'm going to share my screen. Let's see if we can get started. Here we are. Okay, so you should see a big blue introduction slide.
Yeah.
So what I'm going to be doing today is a mixture of two different things. I'm going to be trying to give a little sort of educational talk, almost like a mini lecture on difference in difference methods, especially on the basics of the difference in difference methods. So the first half of the talk will have is sort of pitched at a fairly introductory level, with some simple charts to show what a difference in difference estimator does. So if you're quite experienced in statistics or econometrics, you probably will find that first half kind of basic and simple, but hopefully it will still be useful to think about. And then in the second half, I'm going to try and talk about some more modern updates of the difference in difference methodology. I won't be able to talk about the methods in a lot of detail, but I'll be able to touch on some of the key aspects that they address. I'll be applying those, I'll be presenting some of our research from the measure study, which I've given the website for here. And the measure study is a large study here in York where we're evaluating an NHS policy change to introduce new types of hospital facilities in different parts of the country to improve sort of care productivity. So that's the aim. I need to move to the next slide. Here we go. So this the part where I'm presenting actual results is funded by the NIHR. I should also say that the results, any results shown are preliminary, so please don't cite them at the moment. They're still this is still a very work in progress project. So these are the two parts: a broad introduction to difference in difference, and second, showing the modern difference in difference methods in practice. And partly I volunteered to do this seminar because I've actually not have a lot of experience in difference early in my career, and it's only in the last couple of years, especially as part of this project, where I've started using it a lot more. And so it's actually it's been useful for me to develop this presentation to cement my own sort of learning on the topics. So I'll be aiming to finish that first part for timekeeping purposes by 9:25 or so, then move on to part 2 and leave some time for questions and discussion at the end. Okay, so this first part, I'm going to be using a simple X and Y axis through most of it to try and illustrate the idea of differences from the very most simplest possible sort of framework. So in this, we're interested in differences when we're interested in evaluating a policy or another type of intervention where we don't have a randomized trial, for example, but we do have some data. So in this case, we must have data where we're measuring outcomes of interest here on the y-axis. And we can measure those outcomes at different points in time. So here's one observation where we've observed some outcomes at a certain point in time. That might be health outcomes, economic outcomes, or cost outcomes. But we have to be able to observe them both before and after some intervention of interest. And we're interested in evaluating the effects of that intervention. So at this point, as I said, I'm starting very simple. It's worth noting how people often talk about the effects of interventions casually with respect to their own life. In political debate, for example, when politicians are talking about the effects of their policies. And they often do that in a very simple way, something like this. And this is essentially what you would call a before and after analysis. And this is very common sense. So we're thinking of before the intervention, our outcomes are at this level. After the interventions, the outcomes are at this level. So we've decided that the intervention has increased outcomes in this case because the second observation is higher by this amount. So it's important, what I want to highlight here is the assumption behind that very simple before and after comparison, which I'm sure is obvious to all of you. Okay, so without the intervention, the outcomes would have stayed the same. Okay, so there would have been no change in the outcomes if the intervention hadn't happened. And of course, this is a very strong assumption. And because it could have been that outcomes had gone up even without the intervention happening. So our dotted line showing the counterfactual, and I'll use the word counterfactual a few times. Counterfactual means what would have happened without the intervention. What is counter to the factual? What would have happened without the intervention actually happening? So it could have been, our assumption initially for before and after is that the counterfactual is down here, exactly where the before observation was. But it could be that the counterfactual is here, that actually without the intervention, the outcomes would have increased. Or of course, and that means that the treatment effect is smaller than it would have, the treatment effect in this case is smaller than it would have been if the outcomes had remained at the same level. Or, of course, outcomes could have reduced without the intervention. So things could have got even worse in this case if the outcome is something positive, like quality adjusted life years, for example, or health related quality of life. Outcomes could have reduced without the intervention. So that would mean that if we observe a higher outcome after the intervention, the treatment effect is even larger than it would have been with a simple before and after with this estimate. Okay, so I told you we're going to start simple, so I hope that's clear to everyone. Of course, what we're going to do in difference is use some extra data. So we're not just going to use data from before and after for the treated group, for a group of units of individuals, of hospitals or provinces of a country which experience the treatment. The other feature of indifference is that we have to have data on some kind of control group. we'll talk about what the control group could mean later. The control group could be a group of units or individuals which still receive the treatment, but a bit later, or receive a different type of treatment, or it could be that all units are treated, but the control group is some different type of outcome that is not affected by the treatment, for example. So there's different ways of defining a control group, but in order to do some difference in difference analysis, we need to have a control group. And here I've highlighted those. So we've got another set of observations before and after the intervention, in this case with the sort of dashed line around the circle and highlighted in green. So how does that help us? We know that the intervention treatment group had an increase in outcomes of this level, and the control group had an increase in outcomes of this level. Well, obviously we can see the increase in outcomes experienced by the control group. And we can use that increase in outcomes experienced by the control group to infer what would have happened to the treatment group if the treatment hadn't happened to them. So the treatment group here had an increase in outcomes, but the control group also had an increase in outcomes, and we can draw their increase here and just move it up to what would have happened here for the treatment group if the treatment didn't occur. And what we're doing here is estimating this counterfactual, what I'm highlighting in a red dot here. That is what we have to always do in any type of experimental evaluation. We have to come up with an estimate of what would have happened to the treatment group if treatment didn't occur. So the difference in difference analysis is just giving us a different way of coming up with this counterfactual. Before, when we were just looking at before and after, we decided that the counterfactual is that everything would stay the same in the treatment group. So when the treatment happened, we compare their new outcome with what outcomes were before, so that's making the assumption that outcomes would stay the same. With difference in difference analysis, we can make the assumption that the treatment group might not have stayed the same without the intervention, so outcomes in the treatment group might not stay the same, but they would have followed the same pattern as the control group. Notice that's not the same as assuming that the outcomes in the treatment group would have been the same as the control group, because the control group before the intervention is different. That's in comparison to, for example, in a clinical trial, where we would usually start with outcomes in the treatment and control group being the same. I mean, they might not be exactly the same, but randomization would usually ensure we have a treatment group and control group that have roughly the same value of measured outcomes, some health outcomes, let's say, before the intervention, before patients are given a drug, or before a policy is implemented. You would look at two groups, a treatment and control group, that have the same outcomes before the intervention. And then you would just measure the difference between them after the intervention. That's not that assumption. That's not the process in difference. We don't have to assume, we don't have to have outcomes being the same in the treatment and control group before the intervention. They can be different. In this case, I've shown the control group having lower outcomes before the intervention. What we do have to assume, as I've shown here, is that the trend in the treatment and control group would have been the same if the intervention hadn't happened. And we have a name for that in the difference in difference literature. That's called the parallel trends assumption. So the assumption that without the intervention, outcomes in the treatment and control group would have evolved in the same way. And the parallel trends assumption, to some extent, sort of is what difference in difference analysis is. That's sort of understanding the parallel trends assumption and what it means and how we can provide evidence for and against it, for example, is really the whole thing in terms of understanding difference in differences. So it's that assumption we make about the counterfactual for the treatment group, that it would have been followed the same trend as the control group. Now, we can't test the parallel trends assumption, but one thing we can do is provide evidence for and against it. We can't test it because we can't get this data point here. We can't get the counterfactual for the treatment group. What would have happened to the treatment group if they weren't treated? Without a randomized trial, we can't know that. But we can provide evidence, and one way, obvious way we can do that, that you can show in a graph, is by looking at trends for data from earlier time periods before the intervention. And we'll be talking about that in a bit more detail later. Okay, now I've defined in the graph by looking at the changes and outcomes in treatment and control group, what the difference in difference estimator is. We can start adding a bit more structure around that. And one way of doing that is to define the difference in difference estimator with a bit of algebra. This is what's often called the potential outcomes framework, and it's the way that people often define before and after treatment for the treatment and control group, and therefore you can come up with a simple expression for the difference in difference estimator. So I'll explain what and understanding this sort of framework is useful just for reading the papers and understanding the literature in difference in differences. So I'll try and do that now. So first of all, all four of these expressions is y. Y is the letter that we usually give to outcomes of any type in econometrics. If you're used to econometrics, y is on the left-hand side, x is on the right-hand side. So here, y is the outcome. That's the only reason it's y. It could be any other letter. The subscript is whether the data is observed before or after the intervention. So that's just the time period of the data. Is it 0? In this case, we've got two time periods, 0 and 1. So before the intervention, both of these are 0 and both of these are 1 for their subscript. The superscript, that's the higher letter here. I've given it sometimes that's another number, 1 and 0. I think it's easier to call it T and C here. So for treatment and control, that other superscript here is determining whether that observation is in the treatment group or the control group. So here we have treatment and control, treatment and control. And the number in the parentheses is whether the treatment has occurred for that, whether that observation is of a treated unit. Okay, so whether that unit has received treatment at that time or not. So that's sort of the really important one. And you can see 3 of them are 0 and 1 of them is 1. That's because before the intervention, neither the treatment or control group has received treatment. So they're both 0. After the treatment, the control group still hasn't received treatment. So the control group may be a group of hospitals which hasn't been subject to the policy, or a group of provinces of the country that hasn't been subject to a policy. That control group is still not received the treatment, but the treatment group has. So that the treatment group has a 1, and that's the only one that has a 1. So once we've defined those expressions, we can write out the difference to difference estimator. There's actually 2 different ways of doing it. You can look at the change in the treatment group and the change in the control group, and difference those 2 out. The way I've written it here is the difference before and the difference after and the difference before the treatment. So what I've done here is the difference after the treatment, so these are both y1, between the treatment group and the control group. In this case, that's the positive number, which is this purple arrow here. So that's the difference in outcomes between the treatment and control group after the treatment. But of course, before the treatment, there was also a difference between the treatment and control groups because we haven't randomized the groups. They were different before the treatment. So we have to subtract from our difference after the treatment, the difference before the treatment, which is the outcomes measured before treatment for the treatment and control group, neither of which obviously has been subject to the treatment. That's why they both have 0 in the parentheses. Okay, I hope that's clear. So that's one way of showing the difference in difference estimator, is just by literally all you need for the most simple type of difference in difference estimator is these 4 numbers, the treatment, the outcomes, measured before and after the treatment for the treatment and control group. And if you have those 4 numbers, you can use this expression to calculate the difference in difference estimator. Okay, what's more common in health policy and most other types of research is that you have more than 4 data points. Often you have information at a lower level, so you have information for measured for individual hospitals, for individual patients, or for different regions of a country, different administrative regions. And so when you have that type of data, you can't just do that simple and subtraction of 2 differences. You have to usually use a regression framework to do that difference in difference model. And this is the simplest version of what that regression framework can look like. It's a regression framework because we have outcomes on the left-hand side and we have an error term on the right-hand side. We have an intercept term and 3 coefficients, beta 1, beta 2, and beta 3. Beta 1 is defining the difference between the treatment and control group, but it actually defines the difference between the treatment and control group before treatment. So all of these are 0, 1 variables. Okay, so the treatment variable is just 0 if that unit is in the treatment group, in the control group, and 1 if that unit is in the treatment group. And the post is for after treatment, so that's 1 if the unit is observed after the treatment, whether or not they've been treated or not. And the treatment times post is equal to 1 only if that's a unit in the treatment group observed after treatment. So that's why this beta 3 is going to measure our difference in difference estimator. And we can actually relate these coefficients to the graph we've been looking at. Okay, so beta 0 is the essentially the level of outcomes in the control group. Beta 1 is the difference between the treatment and control group, but before treatment. Beta 2 is the increase in outcomes experienced by the control group. And then beta 3 is the additional treatment effect once you've added beta 0, beta 1, and beta 2 up. I'm running a little bit behind time, so I've got a few more slides of this basic introduction to difference in differences, but this is covering most of the material I wanted to get through. I've now got some slides with text. I'm going to go through a little bit quicker before we can get on to the part 2, where we use an application to our project using data from the NHS. Okay, this slide just describes the graph that I just showed there. So the role of beta 1, beta 2, beta 3, and beta 3. And beta 3 is capturing the additional change in this treatment group beyond what occurred in the control group. So therefore, it is the difference in difference estimator, the causal effect of the intervention under the parallel trends assumption. That's the key assumption of the difference in difference approach. Okay, I want to talk a little bit more about the parallel trends assumption. I think I've talked about it quite a bit in the graph. So I'll say that, of course, the difference in difference approach relies on this assumption. We can't directly test it, but there's several different ways that we can provide evidence for or against it, including event study analysis, where we look at data from earlier or later in the time period, and we estimate for each individual time period a treatment effect, and I'll show that in the second half. Placebo tests are where we try and estimate a treatment effect where we don't think there should be one. So we can define the treatment period wrong in a wrong way. For example, we could pretend the treatment happened at a different period, earlier or later, and we would expect to find a different or 0 treatment effect. We can look at groups that did not receive the treatment. So we can sort of misclassify the treatments. So pretend the treatment group is a different group who didn't actually receive the treatment and estimate the model, and we would expect to find a 0 result. Or we can look at placebo outcomes. That's where we look at an outcome which we don't expect to be affected by the treatment, and we wouldn't expect a positive outcome. We can also examine multiple different control groups or group-specific time trends. I'll talk about some of them a bit later. And there's some extensions to basic difference in difference to more complex settings, including multiple time periods, multiple treatment groups, and staggered adoption. And I'll talk more about staggered adoption in the second half. So the summary of what we've talked through here in part one is that difference in difference analysis is a really useful tool for estimating causal effects of interventions. So in particular, in general, people would consider it better or an advance upon just doing a before and after comparison, because you have a control group which you use to estimate what would have happened to the treatment group without the treatment. That's what we call the counterfactual for the treatment group. And the key thing is that the method relies on an assumption called the parallel trends assumption, which you can assess through additional analysis, but you can't test it for sure. So you can't know for sure whether your parallel trends assumption is satisfied. And there's various extensions to difference in difference models that I touched upon. Okay, I hope that was useful for an introduction. What I'm going to do, I wanted to make sure I didn't run out of time, because the second half probably is a little bit longer, has some more text in it to talk through, and involves quite a bit of describing the data, describing the intervention, things like that. I'm also going to return to that graph and diagram to show the impacts of considering staggered adoption in difference in difference models. And this is using some data and results from the measure study, which has a lot of other co-authors and researchers involved, and I will name check some of them at the end. I can see there's something in the chat. Is there anything? We can talk about some of those questions at the end, if that's okay. Okay, so the policy the project I'm going to be talking about and the data I'm going to be talking about is evaluating a policy called surgical hubs in the UK NHS. This is quite a recent policy, so it's something that was only initiated in 2020-21. I've actually said here it was initiated in 2021, but some of the earliest surgical hubs in our data occur in 2020. Initially, it was a sort of response to the pandemic. The idea was to create hospitals or areas of hospitals that didn't have any COVID-19 patients and could focus on treating elective surgery patients. But it was also formalised as part of the elective recovery plan of the NHS in 2022 as a way of increasing productivity and expanding capacity in the NHS. So what is a surgical hub? It's an NHS-run facility. It could be a separate hospital, or it could be just part of a hospital. The important thing about it is that it should have ring-fence staff. So, for example, surgeons and nurses, and theatres and ward space, which are ring-fenced for elective surgery. Ring-fence means that they shouldn't be used for other purposes. For example, they shouldn't be used to treat emergency patients, and so they shouldn't be blocked up by more emergency patients come to the hospital. They're ring-fenced for elective surgery. We use the word elective surgery in the UK NHS to mean any, not things that are optional necessarily. Sometimes it can sound like optional, but it means surgery which is not an emergency surgery. So sometimes it's called planned surgery or just non-emergency surgery. So things like hip and knee replacement operations, cataract removal, various different types of surgery where you're okay to wait for a few weeks or a few months. You might be experiencing symptoms and it might be unpleasant to wait, but it's not an emergency where you have to be treated, on the same day or within a few days. That's what elective surgery is. That's what a surgical hub is. As I said, it can be a separate hospital or within a hospital. Some of these surgical hubs have been sort of new buildings that were built using new funding from the government. Others were just hospitals sort of reorganizing themselves and setting up certain areas or buildings to be used as a surgical hub from their existing facilities. So I hope that's clear. And what I've shown in this diagram here is that this is a policy which didn't happen at the same time everywhere. This shows that NHS trusts in the UK started opening surgical hubs at different times. Okay, so the aim of this project is to evaluate the effect of new surgical hubs on volume, length of stay, and waiting times. I won't be talking about waiting times here. Okay, so the sort of data we're using here is hospital data called hospital episode statistics, aggregated to the trust level. That means we're not looking at individual patient level data, although you can do this type of analysis for individual patient level data, as long as you're not looking at volume of patients as one of your outcomes. Because we're looking at volume of patients for one of the outcomes in this, what I'm presenting today, we've aggregated the data to the hospital trust level. The hospital trust is an organization that runs hospitals in quite a small area. So usually they have one main hospital and a few other smaller hospitals, but they're run by one organization. The data is at quarterly level and for about 10 years from 2014 to 2024. So we have quite a long period of time before there were any surgical hubs. We will just be looking at elective hip and knee replacements. We have a treatment group, which are NHS trusts, which opened a new surgical hub in this period of time, 2020 to 2023. But not all of them open them at the same time. So they open them at different times. And that's 26 trusts. Our control group is NHS trusts that don't have an elective surgical hub. That's 74 trusts. And there's quite a lot of other data that's excluded that I won't go into at the moment. The main outcomes I'm going to present today to you, at least, are just the volume of procedures per quarter. So that's the volume of surgeries of this type. That's elective hip and knee replacements and length of stay. I'm also going to be looking at a placebo outcome, which is about diagnostic tests, which shouldn't be affected by surgical hubs. So I'll be presenting results for an outcome where we don't expect there to be an effect. And that's part of the what I talked about in part one as one of the things you can do to assess the assumptions behind difference in difference. Okay, so I have to have another slide of equations, I'm afraid. This isn't similar to, I'm going to try and relate this to the slide I showed before for difference in difference analysis, where you have a regression equation. There we had an indicator for the treatment group, an indicator for time period, whether it was observed before or after treatment, and an indicator for treatment times the post times the time, sorry, the treatment group times the time period, which defined whether that unit had received the treatment or not. What we're going to do here is rewrite that in a similar way. We still have, this is called, the lambda is a time invariance fixed effect. So it's a fixed effect for each trust. That will include controlling for trusts that have a surgical hub and trusts that don't have a surgical hub. So that's similar to the treatment indicator, the trust fixed effects. So this approach, I should say, is called two-way fixed effects. And that's because it's two-way because you have time and individual fixed effects. Here, the individual is the NHS trusts. The time fixed effects allow for any common time impacts on hospitals, including whether they're before or after the intervention. So it's also like the post indicator in the simple example I showed earlier, but it also controls for other things that are changing over time, like seasonality and the pandemic. So that's these two. This is like the treatment group, and this is like the post indicator. Now this, what I've called just here the surgical hub, that's another variable equal to 0 or 1 that says whether that trust has an open surgical hub at that time or not. So that's equivalent to the treatment times the post time indicator. So it's whether that NHS trust is in the treatment group, so has a surgical hub that opens at some point in the data, and whether it's after that particular trust surgical hub has opened. So that's why this is the difference in difference estimator, the beta 1. There's also a few other things going on here, like we sometimes allow for trust-specific linear time trends. And what I would say, this is called the two-way fixed effects approach, is that this was often the standard, a pretty standard way of doing difference in difference analysis, where you had staggered adoption, so the treatment being applied at different times to different units, up until about 7 or 8 years ago, so the late 2010s, certainly as far as I was aware. What happened recently is that there's been a lot of new literature in the late 2010s and early 2020s showing there's some problems with using the two-way fixed effects framework in the way I just described, especially when there's staggered adoption, so treatment happening to different groups at different times, and when there's heterogeneous treatment effects, that is different treatment effects across units and over time. And you might think about how that's likely to be happening for surgical hubs, where different surgical hubs are opening in different hospitals, so they're not all the same, so they might have different treatment effects, and they might have a treatment effect that grows or reduces after the initial impact of the hub opening. In particular, I'm going to refer you to this paper by Andrew Goodman-Bacon, 2021, which now is called the Goodman-Bacon decomposition. And he's shown how two-way fixed effects models for difference and difference mix together different types of comparisons. That's kind of obvious in the sense you're comparing, first of all, you're comparing treated to never treated units. That's what you do in all difference and difference models. You're comparing a treatment group to a control group. But you also have treated units being used as a control at different time periods because the treatments happen at different times. So you have the earlier treated units being compared to the later treated units, where the later treated units are being used as controls. So for hospitals that don't have a surgical hub opening early in the data, they are still in the control group and they only become in the treatment group later when their surgical hub opens. You also have something called the forbidden comparison. That's where later treated units, so hospitals that have surgical hubs that are opening later in the data, are compared to hospitals that already have a surgical hub opened, because once the treatment has occurred, it's like those units revert to being in the control group. Certainly in the way that two-way fixed effects models estimate the effects, they use this forbidden comparison as well as these other two comparisons. And this particular comparison, the later compared to the earlier treated units, is particularly problematic when the trends change after the treatment happens. For example, when the treatment effect grows over time. So I'm going to try and illustrate that. Here is our previous graph showing the treatment effect, where we've made a parallel trends assumption to find the counterfactual here. What would have happened to the treatment group if the treatment didn't happen? Now, what I've done now is added a second intervention. And what was the control group before? The green, the second line down here in green. They now have the treatment at this second period, an intervention 2. Okay, so instead of following their parallel line, they now have an outcome measured in the third time period here, which is a bit higher than the parallel trend. So I've shown it like they have a slightly different treatment effect. So the treatment group 2 has a slightly smaller treatment effect here, and this is the original treatment effect shown for treatment group 1. I've also added another group, a control group, which never receives the treatment at the bottom here. But you don't necessarily have to have a group that never receives the treatment. We do in the surgical hubs case, but you don't have to. What I've also shown is that after the first treatment group receives the treatment here, we observe them again in the third time period, but their trend is no longer parallel. Their trend is now steeper than it was before, so their outcomes are increasing more quickly. If they've had the policy, for example, maybe the policy took some time to take effect, and so there's sort of a further increase that happens into the third time period, even though they were treated back in this time period. So their treatment effect should have been here, but actually we observed the trend changing. So this is the forbidden comparison I've shown here in red, and this is just one of the comparisons that is used by a two-way fixed effects model to calculate treatment effects in a difference in difference model, and it's not ideal or forbidden because it involves comparing a group that's treated for the first time here, so trying to estimate this treatment effect. You can compare it to the control group. That would be the ideal comparison. But in the two-way fixed effects model, it also compares it to already treated groups like this one, And in this case, I've shown that the already treated group has a different trend, which would change the treatment effect here and could in fact bias it. I think that's all I can do in terms of explaining that in the time I have available. But that's one of the main features of this new literature around staggered adoption and difference in difference. That there's this particular problem with the standard regression approach, and so you need to use different approaches to estimate the treatment effects. So this is the same slide as before, but with the point at the bottom here I've added, which is that there's these modern difference in difference methods that rule out the forbidden comparison. So they're designed to only use certain types of comparisons between treatment and control groups, or between earlier treated units and comparing later treated units. Comparing earlier treated units to later treated units, so that later treated unit is still like in the control group. But also, we carefully deals with this issue of how to weight all these different comparisons and make sure that they're equally weighted if that's what you want, for example. Okay, I'm actually going to, I'm again running a little bit behind where I wanted to be. So because I want to start show some results before we get to the end. But basically, we use some of these modern methods. We use this Barusiak et al., which I'll call BJS, and Callaway and Santana CSA as two of the additional methods. We also estimate the model with an event study approach that's shown here, where we allow for treatment effects before and after the treatment occurs. And I'll show what that means in the graph. Apart from that, this is a similar setup to before. This is what our data looks like. We have data on volume of procedures per quarter. So this is volume of surgeries, hip and knee replacement surgeries. I've divided them here into groups, trusts that don't have hubs open and trusts that do have hubs opening. You can see that so this is like the treatment group and the control group. You can see that the treatment group does have a different starting point. So it's already a higher volume than the control group. For length of stay and waiting time, they're more similar. I won't be showing results for waiting time. Okay, I want to get showing some results. So these are regression models where each column is a different regression model, and they're all trying to estimate the impact of opening a surgical hub. So post-hub is the impact of is when a surgical hub is opened in a NHS trust. What we're expecting is a positive number here, showing an increase in procedures associated with the opening of a surgical hub. As I said, we've got 5 different models here. The first model, the first 3 here are two-way fixed effects models. So they're standard two-way fixed effects models, just like the standard difference in difference I showed earlier, but where we've got the staggered adoption. But we add different types of fixed effects at different times. So model 1 is before we've added the time fixed effects, which we know that this model is wrong. But it's always interesting to see the difference when we add time fixed effects. So when we control for time trends between model 1 and model 2. So in model 2, and for all of the rest of the models, we always recover a positive coefficient. So an impact of surgical hubs on increasing volume of procedures. The mean is around 200, so between 238 and 164. So this number, that's around 12%. This is around 25%. Sorry, no, I think this is around 30%. So this is around 25% or so, and this is 17% here. So these are numbers of between sort of 15 and 30% increase in procedures as a result of the surgical hub. Now, talking about a little bit about the differences between the models. In model 3, we're adding provider-specific time trends, and we do see a change in the results here. Although they're both positive, it becomes statistically significant once we add the provider-specific time trends. These two models are the modern approaches that avoid the problems of the comparisons that we see in the two-way fixed effects, including the forbidding comparison. So this is the Barusiak model and the Callaway and Santana. And luckily for us, both of these models do find sort of similar orders of magnitude. It's worth looking at the standard errors here underneath. So we don't expect these to all be estimated exactly the same number, but as long as one isn't 1,000 and the next one is 100 or something. So we see these are all, between 20 and 50. And they've got fairly wide sort of standard errors, but they're all showing a positive impact of surgical hubs. That's the basic story for volume. This is what I mentioned as a event study plot. So in this model, instead of just having one number to summarize the results, summarize the estimated impact, we can look. This is the point when the surgical hub is opened. So the data, this is the estimated coefficients, imagining that all of the data is lined up so that each hospital opens a surgical hub at point 0. And this is the average increase in volume of procedures at that point in time. You can see, in general, it's a bit up and down here, but this is it seems to go up by somewhere between 30 and 60. It's somewhere around 45. In fact, the estimate was for 45. Get my pen back. Here we go. And it seems to stay sort of roughly constant. We can also see that before the intervention, again, it's a bit up and down. It's actually a little bit more volatile. Remember, this is also during COVID happening and other things happening. We're trying to control for all of those things with time fixed effects. But there's no clear evidence of this thing sort of already going up or even already going down before the intervention. It's kind of bobbing around 0 before the surgical hub opens, which is what we want. We wouldn't want to see an impact of the surgical hub before it opens. That might be a sign of the parallel trends assumption being violated. Okay. Now I'm going to do the same thing, but for length of stay. For length of stay, again, ignore model 1, because I'm running out of time a bit. Model 1 is before we've added the time fixed effects. For the rest of the models, the two-way fixed effects models here, both show reduction in length of stay of around 1/3 of a day. This is in days of length of stay, so that's reduction in the average length of stay of around 1/3 of a day. That's around 10%, because the average patient stays in hospital for around 3 to 4 days. We also see in the Burushack model, the BJS model, a similar number, slightly smaller, but not surprising because we know that things jump around a bit. But we do see the Callaway and Santana model, a very different estimate, much smaller and not statistically significant because the standard error is larger for Callaway and Santana. And we know why that is, and we could describe that if anybody's interested. But what we see when we look at the event study for length of stay is that here's the impact we're estimating. So reduction in length of stay after surgical hubs are opened. That's what we expect because surgical hubs are trying to treat patients more quickly, so get them in and out of hospital more quickly. So we are sort of hypothesizing a negative impact on length of stay. But what you can see before the in the event study here is that before the surgical hub opens, something suspicious is happening here, because in all these observations just before the opening, it's already negative and sort of nearly statistically significant in this one. And in the earlier time periods, sort of up to 2 years, these are quarters. So this is up to 2 years before the opening, it's much higher. Essentially, there's already evidence of a pre-trend in the data here, that it sort of looks like it might already be going down before the surgical hub opens, which is a sign of a violation of the parallel trends assumption, or that the parallel trends assumption at least was being violated before the intervention happened. Okay, I want to get to the end. This is our placebo model where we have an outcome which we don't expect there to be an effect. So this is showing the impact of surgical hubs on diagnostic tests, which are not done in surgical hubs, so it shouldn't make a difference. This is the model without time trends, so we can ignore that positive impact. That's a sign of diagnostic tests growing over time, essentially. Once we add the time fixed effects and provide specific time trends, in these two models, these are just the two-way fixed effects models. I haven't shown the other ones here because I ran out of time to do that. We see these are very close to 0. This is a logarithm, so this is like a 3% or a 2% change, but the standard errors are much larger, so we know that these are not statistically significant. When we look at the event study for diagnostic tests, And, it's a bit of a sigh of relief when we see this, because we would not like to see that this goes up here, because we don't expect that surgical hubs should affect diagnostic tests. We think they should stay the same. And so it is, you can see none of these are anywhere, there's some of them are positive, but none of them are anywhere near statistically significant. Okay, so to summarize the results, surgical hubs seem to have increased procedure volume by somewhere between 15 to 30%. We found some evidence of reduction of length of stay, although the event study plots suggest there might have been a parallel trends assumption violation, so we wouldn't trust those results too much. And we see some differences between the two-way fixed effects and the modern approaches. We also use this placebo model I've described, which is not expected to be impacted, and that has null effects and no visual evidence of trends in outcomes, which is suggestive evidence in favor of our research design. Okay, so last couple of slides that hopefully this provides some sort of some lessons for difference in difference methodology, or at least showing how we've used difference in difference methodology. We've got a policy with staggered implementation and possible treatment effect heterogeneity, because these hubs were introduced at different times and are different in design. We've got issues with parallel trends that I've tried to illustrate with respect to length of stay outcome. We've got some differences in the methodology, how the methodology affects the findings for some of the outcomes, and I've used the placebo model to sort of verify our approach. So the three takeaway messages I've got from the whole talk overall is that difference in difference is a powerful tool for estimating causal effects of policy changes from observational data, and it's crucial to make this parallel trends assumption and understand it to interpret the effects. There's modern refinements to difference in differences analysis which help ensure valid estimates where there's staggered adoption of interventions. And there's quite common sense, I would say, robustness checks, such as visualizing pre-trends in event studies and running placebo models that can help to ensure valid results. Thank you. Sorry, I went on a bit longer than expected.
Thank you, Dr. Pete. And I must say that was an knowledge enriching hour, and I'm really glad to see that how you reconcile the methodological issues with the practical application of a state-of-the-art impact evaluation method. And I'm sure that this particular approach will definitely encourage a lot of young minds who want to build their career in the impact evaluation health research. I have got a couple of questions in the text box for you. So the first two questions from Selena Siddika, and that's from the first part of your presentation. And it says that, is there any hard and fast rule for selecting control group for difference in difference analysis? And the second one is it also applicable for individual level data? I mean, can difference in difference analysis be applied for the individual level data? So if you can address these two questions first, then I will move on to the next one. Thank you.
Yeah, of course. So no, there's the rule for selecting a control group is that you want to select a control group that would is likely to meet the parallel trends assumption. So that's the rule that there is, I suppose, because we need to make the assumption that the trend in the treatment group would be the same as the trend in the control group. So in the case of surgical hubs, we're using other NHS trusts that have not opened a surgical hub. Now, we don't know that is going to be always a good control group, because it could be reasons why they've done that, and that's just a problem with observational data. But because we can look at the pre-trends and things, that can help provide evidence. Yes, and of course, it is applicable for individual level data. In fact, the length of stay outcome I looked at here, we have actually done those regressions where we look at individual patients as the outcome. Now, the change is obviously the treatment is happening at the hospital level. So we still got most of the effects happening at the hospital level, but you can control for patient level characteristics, for example, covariates. I didn't talk at all about controlling for covariates here. So for trying to control for things that would make the control group or the treatment group more comparable, but you can do that as well, of course.
Yeah, thank you, Dr. Pate. I can see the next question is from Saim Arif, and it says, what is the basic difference between BJS and CS methods?
Yeah, sure. So the difference between them is how they're both methods that don't just estimate a regression function and the two-way fixed effects and then look at the impact with just a variable for the treatment. What's the difference? It's quite hard to describe what the difference is. The BJS model, the Brush-Jack model, still uses something that's more like a regression to model the counterfactual. So they have a regression, it's called imputation, for measuring or analyzing what is happening in the control group before the intervention and using that to impute what the counterfactual. So what would have happened in the treatment group if they didn't receive the treatment? So if surgical hubs didn't open. So they're using all the data. They're using a much longer time series trend of the data from before the intervention to estimate that counterfactual. The Caloen-Santana model, the CS model, is less efficient because it's analyzing each intervention separately. It's almost like doing a separate difference in difference model for every surgical hub opening in our data or for every treatment. So it's looking at them all separately and then averaging the results. That's my attempt to describe the difference between them. But I would recommend some of the literature I've put in the, especially this Jonathan Roth paper, what's trending in differences. This is freely available on the internet as well as it's in the journal, but he has a version of this paper on the internet. Yeah, there's lots of different ways you can use to select control groups. I can see Simon also talked about using matching methods. You can use something called synthetic control, which is where you use an average of different units that are untreated to define a control group. There's various different ways of doing that. So there's lots more in this literature that I didn't cover.
Great. Thank you, Dr. Pete. I'm just cautious about time, so there are a couple of questions came up in the chat box. So one from Doug Maui, and it says, "What if we didn't have baseline data, pre-intervention data? Can we apply DiD or any other particular method?"
I mean, not really, of course, because you do, for difference in difference, you do need a change in the data. So you do need to be looking before and after something. Now, if you didn't have data from before an actual intervention, you might be able to look at a control group and look at changes after the interventions and still come up with something interesting. If you feel, for example, if you feel like the intervention is only going to affect outcomes gradually and not instantly, then it still might be useful to look at difference in difference for after the intervention. But it obviously it is a limitation, yes.
Thank you. But we have another question, and I'm afraid that would be the last one because we are already in the final stage of our timeline, and that's from Lee, and it says, "Could you please clarify if the increase in surgical volume is due to these surgical hubs accelerating the procedure and providing more surgeries, or is it because patients from other trusts can be transferred to these trusts with surgical hubs for their operations?"
Yeah, that's a good question. We can't be sure with the outcomes I've shown you so far. We can't be sure about this yet. So that's something we're going to be looking at in future versions of the research. So this is a long project that we're still working on for another couple of years, and we're looking at lots of different outcomes.
Thank you, Dr. Pete. Thanks for enlightening us with your, methods and the, findings. So we are in the last bit of our webinar. Simon, any last words from your side?
Just to say thanks very much to Pete for the really interesting presentation and for yourself for chairing, Abdullah. And just to note that, yeah, this has all been supported by the NIHR grant supporting the DiD grant. So this is part of Chase sort of capability capacity development work in global health research. But yeah, thanks again, Pete. It was really interesting.
Thank you,
Thanks.
Dr. Pete, and thank you, Simon. I would like to, express my sincere gratitude to all of our participants on behalf of HARN, and we would like to, request you to keep an eye on our website and, send us email with your queries and everything. We are happy to, support you on this aspect, and definitely we usually upload our video recordings of the webinars as well, where you can access all the presentation and everything. So keep an eye for the next month webinar, and we hope that we will meet soon again. Thank you so much. Thanks, Pete. Thanks, Simon.
Thanks, everyone.